was recently divorced. I had not worked in 11 years. And I honestly was really worried about what I was going to be qualified to do. And one of the key things that I really enjoyed about my role in the Senate and also in the trade association is working with communities to drive change.
Welcome to the Building the Noise podcast.
Welcome, everyone, to the Building the Noise podcast. I'm Matt Teresco, and joining me today is Jessica Riviere, a longtime tenured individual in patient advocacy in the industry. We've had many guests like Jessica, but none quite like Jessica, and you'll learn why here shortly. Jessica, thanks for joining us today.
Thanks for having me, Matt. I really appreciate the opportunity.
So our goal in this show is to shed light on the fact that not only are there patient advocates that people come across in hospitals or in their insurance company, which we can all laugh about, but in industry, and that there are teams wholly devoted to helping patients who don't know that help exists. So we call it Building the Noise because we're trying to build noise around advocacy, around the need for advocacy and self-advocacy. We have to be loud. Everyone's going to have to be loud ultimately to get what they want. So my first question for you, Jessica, is as you look back at your career, how did you wind up in advocacy?
Really by happenstance at a cocktail party. I had worked in the U.S. Senate. I had worked in a trade association. I had worked in the Office of Legislation and Policy for the Centers of Medicare and Medicaid Services. And I would say the work in the trade association and the U.S. Senate probably prepared me most for the roles that I've had in the past 20 years. But I was recently divorced. I had not worked in 11 years. And I honestly was really worried about what I was going to be qualified to do. And one of the key things that I really enjoyed about my role in the Senate and also in the trade association is working with communities to drive change. Both happened to be in the healthcare arena. So I aged myself by saying that when I was in the U.S. Senate, I worked on the Clinton healthcare reform package.
That's not that long ago.
Way back when, in the 90s. And when I worked at the trade association, I worked at the Massachusetts Medical Society. And in that time, it was the late 80s, early 90s, we worked on two kind of key issues that were impacting medical students and resident physicians. One was universal access to HIV precautions. It was the early days of the epidemic. And there was concern that medical students and resident physicians in healthcare settings were not having the access to the CDC recommended precautions, face shields, gloves, things of that nature. And then in the U.S. Senate on the Clinton healthcare reform, I worked with many, many different organizations that had a perspective on what they thought would be good about the healthcare reform, what they were concerned about, and what their needs were from a reform perspective. So fast forward 11 years, and I met somebody at a cocktail party who said, send me your resume. I work at Bristol Myers Squibb, and I'll see if there are any roles there. And she sent me a job description for an associate director of patient advocacy to support the virology business unit, which at that time had a growing HIV portfolio.
Yes.
15 interviews later.
What?
So that's not only am I a patient advocate, I'm a very seasoned job interviewer. If anyone needs any tips on that. 15 interviews later, I started on January 5th, 2005. And not only was I getting kind of accustomed to working full time in an office setting and learning the industry, but really learning about an incredibly powerful, wildly successful, and unfortunate circumstances that brought their success, but wildly successful group of dedicated both clinicians, people caring for people living with HIV and AIDS, people living with HIV and AIDS, people at risk for HIV and AIDS. And that was transformative. And I spent 8 years immersed in that community. And I really had to earn my stripes. So that was really what made me fall in love
And
with
yeah,
patient advocacy, honestly, to see the inroads that they made, the respect that they commanded and demanded, and really how they made a difference to honor those people that were living with HIV and AIDS that
yeah,
deserved better,
and
that deserved
especially
better and needed better.
yeah, and I would say it's probably especially during the whole ACT UP movement in the late '90s and or mid to late '90s, and the push on Capitol Hill that we've kind of lost a little bit um, in the advocacy community. But one of the things that you had brought up, I want to go back to actually a couple of things. First and foremost, you found yourself in the throes of the federal government. What in your mind has allowed us to get to where we are today from a healthcare perspective, where so many patients feel so disconnected from healthcare?
I think the first is, while there's tremendous benefits to automation and AI and portals and
Mm-hmm.
all of those kinds of things, we've lost the human connection. It's really hard to find a human being that's
Mm-hmm.
going to answer the phone that says, hey, you know what? I am living with breast cancer, and my doctor has just told me that I need this treatment. And I'm terrified because I've got two children that are under the age of 10.
Yeah.
And instead of hearing a human, getting someone picking up the call and listening to your story and helping you and saying, let me help you navigate that. Let's see what we can do. You're in a self-service portal that sends you to all kinds of different things
Yeah.
that you need to upload this
Is
document,
this
you need
what you
this.
meant?
Right.
Yeah.
So I think part of it is the loss of the human connection, and it allows organizations to distance themselves from the reality of what their policies actually do to communities and families.
Sure. Yeah, it's unfortunate where we've gotten, but it's because of work of people like yourself in advocacy that people are getting a voice and recognizing that, ooh, I can vote. And
Right.
I think this next election, may that be the midterms or the general, will be one of the first that's solely around healthcare as the main
Yes.
issue. You know, as they always say, I think it was Carville who said, "It's the economy, stupid," right?
Right.
But when healthcare is 1/5 of the economy, it's hard to argue that that's not part of that same argument. You had
Absolutely.
also right. You had also referenced that you had done some work with some professional societies, right? Am I mistaken?
No, I worked for the Massachusetts Medical
That's
Society.
right.
So the
So,
Massachusetts Medical Society is a trade association largely for physicians, not for patients,
yep,
but for physicians. And it was a good training ground to put me on this side of the street, to
sure.
understand what drives clinicians, what they prioritize,
Mm,
how they approach their policy making and their interest as a profession. So I
sure.
think that was a really good training ground, to be able to understand, what makes them tick, what drives their behavior, what informs their decision making, and as a collective body, how do they influence public policy and the care that they're being asked to deliver in the
Sure.
systems that they work in.
So, for your average patient, what do you think they should know about professional societies, just for their own knowledge?
First, they should know that they exist, because I'm not sure a lot of people understand that
Yeah.
they exist.
Yeah.
The American Medical Association is one of the largest trade associations
Mm-hmm.
in the United States, very well financed.
Sure.
give support a lot of candidates. They have a PAC. They're very influential in dictating kind of how medical care is delivered. I would also say don't just look at them. Think about every specialty has their own trade association. So you
Mm-hmm.
have a giant kind of generalized trade association for clinicians, but you then have trade associations for every specialty from cardiology to OBGYN. And they are drafting and influencing the standards of care. They are
Sure.
writing guidelines around how they think what what the best practice in medicine should look like if you're a gynecologist.
Mm-hmm.
And those trade associations provide board certifications. So they physicians take, board exams that they pay significant dollars for to get a certification to say that
Sure.
they're board certified
That's right.
in a particular specialty. That's not a requirement for licensure. That's something that whole community created themselves, right? It's a money
Ah,
grab.
sure.
And we now use that as a badge of honor that
Yeah.
I'm board certified. But if you look at the history of how board certification came about,
What does that
it,
actually
what does
mean?
that actually mean? It's different than state licensure to show that you graduated from medical school and you did it in an accredited
Institution.
residency. It's
Yeah.
another level of credentialing, if you would say,
Sure.
that clinicians have adopted.
Interesting. On the direct to patient side of ARCO and our business, we have an empowered model in which we're seeking to educate patients directly. And one of the biggest things that we're trying to bring forth is beginning to peel back the onion and understand the incentives in healthcare. And, why do things happen the way that they do? Well, always, if you follow the money or if you follow the incentives or if you follow where the measurements are, you'll begin to understand as a patient why what's happening is happening. So it's great that you've introduced the audience to professional societies, but even more so the credentialing and some of the stranglehold or stronghold that these organizations have on their members as well.
Without question, the other thing that I would remind patients of is the standards of care and the guidelines that they are writing that insurance companies often follow or use as a reference as to what will we pay for this procedure because this is the standard of care. Those standards of care are developed in a long process that the different trade associations have that are predominantly populated by clinicians. They're not bringing
Sure,
in patients to say, hey, women living with lupus, here's what our guidelines look like. And does
sure.
that resonate with what you're
With
trying to achieve as a patient as to what a good health outcome would look like for you? Some of the trade associations are moving to bring some of those perspectives in as
sure,
they look at guidelines. But the reality is, it is, again, oftentimes a very insular process
sure,
of the leading specialists that are creating guidelines. And the question is, what role do patients and patient organizations have to influence what a good outcome looks like for their particular medical condition? Because
it's a
you sometimes have a
wonderful point.
difference of what a clinician might think is a good outcome and what a patient might think is a good outcome. And how do you
I,
marry those two up?
Yes, I mean, I vividly remember being at a rare disease medical meeting, so to speak, where we had brought together the SYNGAP1 community
Yep.
and all of the academics and biotechs that were looking to address SYNGAP1. And all of the researchers were searching for the C word, the cure, right? And a mother raised her hand, and I'll remember it vividly for the rest of my life. She said, I love that we're looking at a cure, but every day my child has multiple seizures and I don't know if that's the last time I'm going to be holding him or her in my hands. Can you focus on that?
Right.
And as you talk about the guidelines and the focus and what treatment looks like as, what's standard of care, if you're not getting the patient input, can we really say it is standard? Who's it standard for?
Exactly. Who's informing what good is? And
Yeah.
that's why patients and patient communities and patient organizations play such a vital role into demanding a seat at those tables.
Yes.
Because
Yep.
without that perspective, you know, and the next question to ask of that mom is, what are the risks and benefits you'd be willing to take on
Yes.
behalf of your child to reduce the seizures? Right?
That's a great
The
point.
drugs that we're looking at developing could have X side effects that are
Mm-hmm.
irreversible. Is that something you're willing to look at? The dosing is rather complicated. Is that something
Sure.
you're looking to look at?
Yeah.
All of those kinds of things, until you put all of those issues out onto the table,
Mm-hmm.
you're not having the kind of discussions that we need to have. It's about benefit risk, it's about cost, it's about
Yeah.
access, it's about dosing, it's about side effects, it's all of those issues. And how does that fit into the reality of your life, right? Because we're not it, none of this happens in isolation. This happens while you're a mom, while you're an employee, while you're a spouse, while you're a parent, while you're a neighbor, while you're a
Yeah.
friend. And so, and those things change as we move through the trajectory of our life. What might be important to you when your kid is 10 may be
Yep.
very different than what's important to you when your kid is 18 or
Yes.
25. And so I think those are the kinds of questions and discussions that need to happen more, not by happenstance, but
Mm-hmm.
really be built into our decision making process.
Sure. It's a great comment there. Healthcare doesn't happen in isolation. I love that.
Right.
That's fantastic. So we've discussed the professional societies and how you got into industry, but the follow-up question I have for you is, why advocacy? Why do you do what you do?
I I love what I do. I absolutely love what I do
That's evident
because
every time we speak. I will say you light up when you get to talk about this.
I
Yes.
I love seeing people suddenly realize the incredible power that they have. And
Yeah.
there's so many stories that I can recount.
Mm.
Anything from the simplest, and maybe not so simple for a lot of people, but feeling like it's okay to go to realize, hey, maybe I don't have the greatest relationship with my physician. I can
Mm.
actually go see if there's another person that I might click with better. Not
Sure.
that the physician that I'm seeing I don't think is qualified, but I don't feel heard. I don't feel seen. And I want to go someplace where someone takes my symptoms seriously, or whatever that may be. So it can
Yes.
be as something as pivotal as that, to then meeting a woman who found out that after her mother died, that her mom had died from a rare genetic condition,
Mm.
and that she had the same gene, and she left her job as a lawyer, and she and her husband went and got PhDs and now run a lab at MIT and
Wow.
Harvard, and are working on a potential cure, treatment.
That's
Like,
amazing.
so
Yeah.
and it's, and I say that there's that continuum. That is
Mm-hmm.
not everybody's going to be everybody's path.
Yeah. Yep.
But that's what's so inspiring, to hear from a parent who's like, hey, I changed my doctor because I wasn't getting what I needed and my child
Yeah.
wasn't getting what they needed. And that was the first time that I felt like I could do that.
Yep.
To,
That I
to
had that
me,
control.
that I had that control, I had that voice, to a person who is like, I don't have any control over the genetics that I have, but I
Yep.
have control over how I can respond to it. And my response is, I'm going to dedicate my life to figuring out if I can't find a cure. Like
Wow.
crazy.
Yes. Yeah.
People,
Yeah.
a guy who is a musician who's just beginning to run clinical trials to find a treatment for his daughter. Like these are the
What?
stories
Yeah.
that you look at that are just mind blowing
They reveal the human
around
condition.
of of being able to make it better. Maybe it won't make it better in their lives, but maybe it will make somebody else's life better. And that to me is, I think that, and then, then one could say, well, then why don't you work for a patient advocacy group? Why are you working
Yeah.
in the industry? I would say um, the industry part is the innovation that companies with this scale can bring from a
Sure.
science perspective. And
Yep.
so you marry that up with this incredibly inspiring group of individuals that are driving change in their lives and their
Mm-hmm.
communities, and you try to marry that up with the science and the resource that a big or even a small company can bring to bear to bring
Sure.
hope and potentially bring innovation and solutions.
Yeah, I mean, you'll go from, instead of, let's say, starting your own lab at MIT, you have a dozen labs like that in one
Right.
company, right? And the funding to do it as well. So that I understand why people move into the industry, and I've spoken with many advocates in industry that were in the nonprofit sector before, and those that have gone the opposite direction as well. Don't get me wrong. There's benefits and take back, so to speak, for both sides. But there's immense value that I've discovered in just helping people to find their own voice. And I
Yes.
think that that's one of the things that you've done really well in not only your career, but in demonstrating here, is that a lot of what advocacy is about is helping folks to recognize who they actually are and what they actually want,
Right.
instead of what maybe a provider wants for them.
Right.
And we get to do that empowering, right?
And they already have the power. They just don't
Yeah.
know sometimes where the outlet is to plug in the cord.
Great
Or they
point.
need
Great
someone
point.
to say, you actually have all the answers. You don't need to be a scientist. You don't need to have a PhD or a medical degree to know what works for you, or what works for your
Yep.
child, or what you think
Yeah.
works for your terminally ill spouse
You can, or
or
you can
partner.
trust your gut,
Yeah.
right?
And that lived experience needs to be much more front and center.
My adage that I've been running with for the last few years has been that the patient lived experience and patient voice is the largest untapped data source in healthcare. Why do you think that remains? Why is it that health systems and to some extent industry don't quite yet see the value of that lived experience?
I think because they're so accustomed, we have kind of a data
Mm-hmm.
fixation.
Mm-hmm.
And I think that they worry about the quote robustness of the data,
Got it.
right?
Sure.
You're
Yep.
definitely seeing patient organizations monetizing data that they have
Yep.
collected,
Registries. Yeah.
patient registries, patient reported outcomes, things like that. But we don't yet see from a regulatory perspective how much that weighs in on an approval with a regulatory agency versus the data that the studies generated from a scientific perspective.
Sure.
Did it
Yep.
meet the end point? Was it,
Yeah.
was the study powered properly? All of
Yes.
those kinds of things. I don't think that the kind of patient data and
Mm-hmm.
perspective, quite frankly, is as valued as it should be or could
Yeah.
be.
Well, it's what's interesting. If I go back early in my career, we can talk about these products because they're both off patent, and this particular company is no longer around. But we had a product for head and neck cancer, colorectal cancer, and we're moving into non-small cell lung. It was an EGFR inhibitor, and progression-free survival in oncology. I don't know if it still is, but it was everything,
It's the
right?
gold standard,
At the
100%. It's the
gold
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 standard.
standard metric. But what I was recognizing, and our marketers quickly began to realize as well, was okay. The disease is not progressing, but the quality of life is just
Yep.
falling off a
Yep.
cliff, right? I mean, it was giving patients this terrible rash that they had to create rash kits, right? Where we're talking sores all over your body type side effects, and trying to go to a patient community at that point and say, but look at the lifespan that you'll have. Couldn't quite navigate the two, right? So we're stuck with, as you referenced, this data fixation. A question I have for you is, how have you, in this environment, helped leadership in other departments recognize the value of the patient voice?
I got to be honest with you, Matt, it's an ongoing battle. I mean, as I said, I started this work over 20 years ago, and there are some
Yeah.
days that I feel like we've come really far, and some days I feel like we haven't come far at all.
Yeah.
I think that, and then you layer in, the promise of AI, that I worry that it's still not really embedded into the work that we do. If you look at most companies, patient advocacy functions remain under-resourced, both
Oh
from
yeah.
a human capacity perspective, from a financial capacity perspective. I think we still struggle with, showing our value because, ROI, we're in this weird conundrum. We can't be viewed as commercial, but then
Yes.
we're fighting against that. We can't show a return on the investment and all of that. So it's a challenge. I think part of that is that with that over reliance on AI and just all these data sources, that we will miss out on and continue to deprioritize that actual connection with actual communities. And
You and
the
I
other
both.
piece, the other piece that I would say is that, those people that participate in a clinical trial, those people that come to an advisory board or serve on a patient council, that's the top 10%. They are incredible ambassadors for their respective communities. But the reality is, for every one person that's at that table, there's probably 10 people that don't even know that table exists.
Yeah. Sure.
They,
Exactly.
that, and I've run into that in many times where it's like, are we actually talking to the people that aren't in the top academic medical center, that don't have the
Yep.
leading clinician in that particular condition that's treating them? Are we talking to the people that are trying to piece things together in a rural setting or a community setting, that their clinician has only ever seen one person, their kid, with that
Yeah.
particular condition?
Yep.
So I think that's part of it, is that, are we really representing what a community's needs and wants and gaps are
Yeah.
when we do some of this work? I mean, we do the best. We're as well
Yep.
intentioned as it comes with the best of intentions, but I don't think we're truly representative of many of these communities. And with all
Yeah.
due respect, most of the people that are in patient advocacy, either at the industry level or that are leading patient advocacy groups, look like me.
Look like you and I. Yes.
It is a white woman,
Yep.
mid-50s,
Sure.
that is doing this work,
Yep.
and that alone tells you that we have real opportunity to broaden the perspectives and create have more people at the table.
And I couldn't agree with you more on the AI side of things. My fear is that we replace the patient voice with a LLM or a conglomerate of qualitative insights and hope that we get it right,
Right.
rather than speak directly to the patients themselves. But as you think about the future and what we're up against, you know, what do you feel that, you've touched on a bit of this already, but what do you feel most people misunderstand about your role, both in the industry and outside of it?
I think within the industry that there's no business impact.
I've seen it
I
and
mean,
heard
I
it
hate
so
to
many
say
times.
that.
Yep.
I hate to say that, but I honestly think that they don't think there's business impact. They would. I think that there are a lot of other roles that they would rather invest in, that that to me are not long-term roles. To me, what I do is over a longer horizon, right?
Yes.
And it's a long-term investment, and it's not a 1+1 = 2 by Friday at 5 o'clock.
Yeah.
And that I can appreciate in a for-profit industry.
Yeah.
That's a challenging paradigm.
Yeah.
But we are not functions of 500 people. We're functions of 3, 4, 5,
Yep.
maybe 10 max,
Yep.
regardless of the size of the company. And so I would say, when you have a company, why are we not putting more investment into that? Because it is still remains a very small cost. And there are certain things you just need to do because they are both a good long-term investment. They give you credibility that you're
Yes.
not going to have if you aren't doing this kind of work. You're
Yep.
not going to get from the market research that they're
No.
selling to every company that's in metastatic breast cancer
Yeah.
or
Yep.
in rheumatoid arthritis or any of those things. So I just think part of it is the biggest challenge is that, or the biggest misperception is that we don't have business
Yeah.
impact.
And I think you had referenced this earlier too, which is to to a large extent, you're not allowed
Right.
to talk about the business impact. And I think that that's important for folks who are outside of the industry to understand, is that we know, if you've done advocacy, as they always say, if you've been in advocacy, there's no slides that you need to understand its impact. If you haven't been, there's no amount of slides that are going to introduce you to its impact.
I mean, I've worked at many companies, Matt, and I wish I had kept over the long run the multiple iterations of how I described what patient advocacy was, what this work was, the impact of this work. It's gotten harder,
Sure.
honestly, which is kind of surprising.
Yeah.
But when I was in HIV, and I think
Mm.
I told you this before, the New York Times did a report card that they published in the
Yes.
health section of the New York Times on an annual basis that graded every company across a variety of different categories. That they had the leading advocates who
Yeah.
were really heavy hitters quoted throughout the article. It was generally like at least a 2-page article. And like, name any CEO who wants to be on the cover of something
Yeah.
negative of the New York Times. Not a single one,
No.
regardless of what industry you're in. So I think that there's a lot there's not the same kind of fear
Mm-hmm.
Because I think industry thinks they do just enough.
Yeah. It's so funny. We started last year. Actually, 2024 was our first year we ran it. We'll have our second one this year, what we call our BioAdvocate Benchmark, which was going and looking at measuring what is the average team size and budget in patient advocacy. And as you referenced, it's very heavily driven by total number of therapeutic areas that a company has products for. But your average team, as you have said, is 9, right? That's big,
And that's
small.
big.
Yeah,
That skews
that
big,
that's
honestly.
it does because you have 2 teams specifically that are 52 and 58 respectively, right? So that drags that number way up. It's probably closer to 4 or 5, but no company is spending more than about it was 0.8% to 1.2% of their annual revenue on advocacy.
I would say that is also inflated. I mean,
Yep.
I work for a large company that has billions of that's probably skewed by the rare disease
Yeah,
and the
sure.
small biotech
Yep.
and startups where you really patient advocacy for many of those organizations because the communities are so
Is it
small.
lifeblood?
They're the lifeblood, and they have little to no revenue, many
Yeah.
for many years.
Yep.
So I think that that's probably skewed. There is no way, if I think about the last like 4 or 5 companies that I've worked with, that we've even come close to what you just described
Sure.
as the total amount of resources put to that.
Yeah.
Like,
Yeah.
I mean, you're talking about companies that are spending $100 million on a TV ad,
Right?
right?
Yeah.
I mean,
Well,
that's what that costs, right?
with
On a TV campaign and
yeah.
buying time and all of that. Like the resources that a patient advocacy function, even if you were talking to the company that had 58 people, I
Yeah.
doubt they have $100 million at their
Oh
disposal
no.
to drive
No.
patient
The
advocacy.
teams in the 50s are averaging less than 20 mil
Right.
in budget, right? So pennies
Yep.
from a sheer corporate perspective, which, brings me to another question that is not one that I sent you ahead of time. So I hope it's not coming out of left field. But when we think about commercials, we think about commercial budgets. What are your thoughts on Kennedy's desire to get rid of commercials?
I think commercials can play a role, not
Mm-hmm.
the role, but a
Yeah.
role. I think that there are only 2 countries in the world that allow
Yeah.
direct to consumer advertising. We're one of them. But I
Us in
think
New
that
Zealand.
us in New Zealand, but I think that they can play a role as long one to in some instances maybe make people not feel like they're not alone and that they're
Mm-hmm.
seen, that someone's talking about their condition, that they've
Mm-hmm.
normalized difficult discussions on, a lot of the medical conditions that people are living with. Some people feel shame. Some people feel
Yeah.
embarrassment. Some people
Sure.
don't feel comfortable raising issues about urinary incontinence or
Mm-hmm.
all kinds of different sexually transmitted diseases, all kinds of
Yes.
different things. And so I think in that like from that view, it may for some people make them in some ways normalize being able to have that discussion with somebody, that they see
Sure. That
someone
makes
like
a ton of
them.
sense. Yeah.
So there's that. I think there's some disease awareness impact, not
Mm-hmm.
that they're necessarily going into all the symptoms, but that they're are elevating certain conditions. And then the other is that for some people there may be a treatment that they didn't know
Mm-hmm.
about, that
Yeah.
they're maybe they didn't know about, maybe their clinician hadn't told them about, and it may spark a conversation, right or
Yeah.
wrong, with their clinician in the next visit, like, hey, I saw this ad, and maybe you're not the right person for that treatment, but you've had
Mm-hmm.
the discussion maybe that is like, hey, this is what I'm looking for. This is what I'd
Sure.
like to solve for. How could we get to that? What would that look like? So On those issues, I think there's benefit.
Sure. Yep.
But I don't think those in isolation are educational campaigns or anything
Yeah.
like that. But I do think for a certain number, I remember talking to a person living with HIV who lived in the South
Mm-hmm.
and hid his medication in a shoebox in his closet,
Yes. Yep.
and a young adult living at home with his parents,
Mm-hmm.
and had not disclosed his status. And his dad saw an ad on a bus and had seen, unbeknownst to his child, seen that label on a medication at his house. And
Mm.
it sparked a conversation. Was it an easy conversation? No. But like there's an example of like you don't know where
Yeah.
that can take you.
Yeah.
And that was probably so much shame and so much self-loathing that you're hiding your medication in a shoebox and you don't want anybody in your family to know and you haven't come out. Like,
Yep.
so I hope for that person that their life has been transformed because of that,
Sure.
right?
I have a similar story of a patient that I had worked with in which COVID forced everyone towards telemedicine. And this person, the only spot that they had internet access at home was in the kitchen. And they had yet to tell their family that either A, that their status, or B, that they were out. And that put a major pressure on this patient when everyone locked everything down with COVID, right? And so this is again coming back to the value of understanding specific patients. And in industry, we always talk about, oh, when you see one hospital, you know one hospital. When you see one payer, you know one payer. The same can be said when you see one patient, you know one patient,
Absolutely.
right?
Absolutely. The last
So,
thing I would want any company, you know, bringing in patient speakers is a really popular thing
oh yeah,
for industry to do. And oftentimes you then hear in subsequent meetings, oh, well, you know, when the person came in and spoke about X, and it's like, that's one person's lived experience.
yeah,
Really important to have that
yep.
perspective, but that
But it's
is
just
not
one.
the sum total of what it's like to live with that condition.
Dead on. Yep. Could not agree more. I really, really appreciate you saying that. As you think about folks that are coming into industry these days, brand new, like Hunter, who's joining us as producer, who's 27, I think 26, going to be 27 here shortly. If they were looking at patient advocacy, how do you describe to them what you do? And what are some of the key elements that you would advise them on and how to execute it appropriately?
I think the characteristics that are most important is one, humility.
Mm.
Two is really being able to listen. Three, transparency.
Yeah.
I never want people to walk away feeling like they're promised something that I can't deliver on. And I want to be fully transparent about why we do what we do, why we do it the way we do. Because I think, you know, the pharmaceutical industry doesn't have the best of reputations,
Yeah.
rightly or wrongly. And so I think for me, that transparency right out of the gates is really critical,
Yeah.
absolutely critical. I also, I think respectful. I think
Mm.
we too often, I call it kind of the Oprah effect, in that people literally are so inspired by their stories and so moved. Like these are people's lives.
Yes.
This is not, you know, 4 o'clock afternoon Dr. Phil, people picking up chairs and throwing them at each other.
Yeah.
These are people's lives, and they have real consequences. And respect and value the risk it took to share something so personal and impactful in their lives. And the second thing I would say about that is this is one aspect of who they are. Living with a medical condition, while it can touch many, many different aspects of your life, I have never met a single person who's living with a medical condition that thinks that's the sum total of who they are.
Yeah.
And I sometimes think that we perceive that the most important thing in their life on a
Is
daily
their
basis,
diagnosis.
hour by hour, is their diagnosis. And I think
Yeah.
that's a really big misconception.
Sure. Great point.
I think as far as one of the things, working in industry, resilience, you have to be incredibly resilient. You need to be resourceful. You need to be able to connect dots. You need to be
Yeah.
able to look at things that aren't in black and white and make connections that will, encourage your business to invest in some of those solutions and activities and partnerships that you think will be mutually beneficial.
Yeah.
So I think that's the other piece, is how do you continue to work with your company to make sure what you're doing is both beneficial to your organization, but beneficial to the organizations and the individuals that you're partnering with.
Yep.
But I think resilience, humility, and patience, because this is a long term driving change is not for the faint of heart. It's
And
a
I'm sure
long
work.
journey, and
Yep.
there are lots of ups and downs, and you got to be willing to weather some serious storms, including if you work on the industry side. A company's like, hey, we're not going to pursue this, we're shutting up shop.
Yep.
And you've spent 5 years developing
Relationships.
incredible
Yeah.
relationships and partnerships, and you've really seen tremendous impact, and suddenly you're moving on.
Yeah.
And that's hard.
Oh,
That's
I
hard.
can only imagine. You've referenced a couple of times that resiliency and the time frame that we have to really look at advocacy through, and I think that is one of the hardest things for financially focused leaders to see, is that you can't expect a 90-day sprint out of advocacy to result in something, right? This
Right.
is the long-term strategic 3 to 5 year play that we're making an investment for the future of the business, the future of the patients, for all of us.
Well, from an industry, the future in your primary customer. I mean, if you want to boil it down to just the basics
If
of
they
the
see the
basics,
patient as the customer.
and I'm not sure that we do, but
Mm,
I think that the reality is, in the environment that we live in, where the costs of healthcare are being more and more transferred onto the actual person
yes.
living with the medical condition, the and all of those kinds of expectations, and that as more people become empowered and informed about what they want, what they don't want, and want to have the power to make choices of what's best for them and their families, you better hope that that person is going to the doctor's office and saying, hey, I'm living with X, and this is what I want. This is the kind of treatment I'm looking for. These are the kind of side effects. And, P.S., what is that cost? What's that going to cost me?
Yeah.
It's one of those things. It's a commodity that's very, very different than, whether I go to a car dealership today and say I'm going to spring for the sunroof and the leather interior and
Yeah.
the heated seats,
Yep.
because healthcare is our lifeblood.
Yeah.
But until we value that as a society, as a right,
Yep.
we will continue to have people that are major winners in the healthcare arena based on how it's structured, and we'll continue to have people that are major losers in the healthcare system.
And that gap is just getting wider and
Wider
wider,
and wider.
right? Yep.
Wider and wider. I had a procedure the other day. Before I had even walked into the healthcare facility, they had given me my estimated out-of-pocket cost and wanted to know if I wanted to pay for it ahead of time.
Before you even got there. Yes.
Before I even had the procedure.
Yep.
And that's what I'm saying. Like the days of you not having any idea of what's going on in your healthcare system, we're facing that at the moment of entry before they ask you what you're there for. It's like, oh, can I see your insurance card? Can we verify your insurance? That's a
And
call today,
how
right?
much you owe us? Yeah.
Right. And so I just think we have, and I get it, they are trying to stay in business themselves, but that human aspect of it, I was shocked. I'm like, no, I'm not giving you an advance in
Yeah.
money
Yeah.
before I've actually even had the procedure done.
Yeah.
And the procedure, honestly, was to decide what would be the best cholesterol drug that I might need to take, of
Sure.
which I didn't end up having high cholesterol. But when I think about having that test, the latest and the greatest, it was a CAT
Yeah.
scan. It lasted 2 minutes. I think it cost $3,000.
Sure.
Like, how many people could we have treated for the cost of that medication,
Sure.
for
Yep.
that procedure? Like,
Yep.
I didn't need that,
Yeah.
but I'm
Sure.
well insured, right?
Yes.
I'm well insured. I have good
Good.
coverage.
Good
I trust
physician.
my doctor,
Yep.
and why not?
Yeah.
But
Exactly.
for every person like me who's like, hey, why not? It's only a $200 copay. There's
Sure.
somebody who's not getting basic health care.
Exactly. Yep. That
So my
$200
good
is
health
keeping the
care
lights
is,
on.
yeah, my good health care is at the expense of treating. I remember when Commissioner Caleb, who was the head
Mhm.
of the FDA, spoke once, and he's like, I love the whole idea of precision medicine, but at the expense of basic care, that's where it falls short for me,
Sure.
because the thousands of dollars we'll invest in one individual, and yet we can't provide the most basic
Basic.
of maternal care, of pediatric care for
Yeah.
our entire society.
Yep.
And that's what gives me pause.
Great. Fantastic point. My last question for you.
Yes.
If you could talk to your 20-year-old self, what would you tell her?
I think what I wish someone had told me was, it's not so much the job, but the people that you'll meet along the way. I went
Oh,
to a
yeah.
highly competitive college. I went and got a master's degree, and it was just the rung, the rung, the rung.
Yep.
And that's not what I will remember when I end my career. What I will
Sure.
remember are the people that I have met along the way that were so transformative in my development and who I am as a person. And I hope that I touched them in some way too. So that it's not, and not everybody wants to be in a role where you're engaging with people. But I knew
Sure.
I wanted to do something in healthcare at 20. And I went to a college where everybody was either going to medical school or getting a PhD in science. And I knew I didn't want to do
Was it
those. Mount
Mount
Holyoke,
Holyoke? Yep.
amazing place. But I knew I wanted to do something in healthcare, and I ended up doing something in healthcare, but it was hard to stitch that together when there were such
Yes.
perceived limited choices at that time.
You're
And
gonna be a doctor?
yeah,
Yeah.
and I'm glad I'm not a doctor. Not that there aren't great doctors, and I have friends that went on to be doctors from Mount Holyoke, but
Yeah.
I love what I do. I think it's being open if you have a passion for something, that passion and resilience will take you really far. And you can carve out something that will marry up both your talents and what you want to do. I was so terrified about what my career would look
Sure.
like.
Hmm.
Um,
At that
and
point in
at
your
that
life,
point,
yes. Yeah.
absolutely terrified.
Yeah.
And that was going to define who I was, right?
I get it. Yeah.
And so I think at this point in my career, I have no regrets.
Mm. Amen.
I have no regrets, and the people that I have kind of collected and met along the way, I wouldn't change that for
That's
anything. And there have been
that's what
tough
it's all
times.
about.
I'm not saying
Yeah.
it's been
No.
all smooth sailing,
Definitely not.
but the people that I have met along the way have changed my life.
Yeah. Yeah. And we get here because of the we're on the shoulders of giants, especially
Yep.
in advocacy, and some great trailblazers there. But you're one yourself, and I appreciate the time that you've given us today. I want to end by just echoing the resilience factor that you referenced, both for if you find yourself in the industry doing patient advocacy work, just continuing to drive forward, know that you're doing the right thing, and get folks on board to see it. And you know where we can have found most of our work at Arco has been being the explainer of the things that most company legal teams won't let their own people say, quite frankly. And resilience also for patients, resilience as a patient as well. That today does not mean it's going to look exactly the same way tomorrow. And as you referenced earlier in our conversation, Jessica, your doctor today may not be your doctor tomorrow. It may not be the same hospital you're at. You have to do what's right for you, but know that there are always options available for you. You just might need to look elsewhere. So we
And
thank
it's
you.
all within your power. You
Yes.
have every right to go up on Capitol Hill. You have every right to go to your state house. You have every right to call your state representative. You have every right to call the hospital you go to and say, I
Yeah.
didn't fill out the survey and say I didn't like the care that I got. I felt disrespected. All of those things are
Love that. Yes.
within your power, and exercise them.
Yes.
No, like
Yeah.
that appeal a denial.
Yes.
It takes courage sometimes, but know that is within your, when things feel so out of control, there are things that will give you a sense of power
Yep.
back. And I would advocate anybody to
Yes.
take those small steps. And
Yep.
those small steps lead to bigger steps.
Could not agree more. My personal story is exactly that. And fighting insurance companies, and after 18 years of opiates, you know, it was just trying to find that other option, push for that other option, fight against insurance companies, fight against their formularies, fight prior authorizations. But you bring up a great point with regards to prior auths. Based off the latest data in oncology, at least, and I'm sure it doesn't look great elsewhere, 99% of prior authorizations are not appealed. Those that are denied are not appealed. That should not be. We
Right.
should, as you referenced, we should be getting that appeal, and we should push for that appeal, and should push our physician and their staff to do that appeal. That
Even
gives
know
the
that an
patient the power
appeal
back.
process exists.
Yes. Yep. Exactly. Exactly.
So I say
Well,
power to the people.
power of the people. I'm with you 100%. I think, as a good friend of mine, Matt Zachary, says, 2026 is the year of the patient, where we try to take the power back. But thank you for what you do in patient advocacy and helping to give others a voice that so desperately need it. So we thank you
Thank
for your
you,
time
Matt.
today.
It was great. I appreciate it.
Fantastic. Bye-bye.
Bye.